Hello friends. Today we're going to discuss about psychiatric aspects of traumatic brain injury. I am Dr. Suresh Badanmat, Professor of Psychiatry, working at National Institute of Mental Health and Neurosciences, Bangalore. In this video, I'll be defining what is traumatic brain injury, signs, symptoms, pathophysiology of neuropsychiatric sequelae, how do they present, what are the different types of neuropsychiatric disorders, epidemiology of these disorders, and management of these psychiatric conditions after traumatic brain injury. Let's understand what is traumatic brain injury. It refers to any injury to the brain that results from a sudden and external force or trauma. Here, you need to understand it should be sudden and also external force. It primarily refers to the brain dysfunction caused by an external trauma or force. So that's a very important component. Traumatic brain injury can present in a wide range from mild to moderate to severe condition it can present. This severity depends upon the force applied, the extent of injury, location of the injury on the brain. All these play an important role what kind of neuropsychiatric disorders it will manifest. The common causes of traumatic brain injury are falls, road traffic accident, sports injury, domestic violence, assault, and military combat. Traumatic brain injury is increasingly documented not only as an acute condition but also a chronic disease. That means it presents in a different neuropsychiatric conditions, neurodegenerative conditions in the long run. Invariably, the impact of traumatic brain injury can be seen for lifelong. Traumatic brain injury affects different life domains such as occupation, social functioning, biological functioning, family functioning, and also the quality of life. Many a time, traumatic brain injury causes a vegetative state in few of the people. As I mentioned, the presentation of traumatic brain injury signs and symptoms depends upon various factors such as severity of the injury, the force applied, the specific area of the brain affected, whether how much is the injury caused because of the primary force, and secondary injuries which occur after the primary injury, that cascading event, premorbid level of functioning, any legal issues, insurance, and promptness of medical interventions. All these play a crucial role. Let's understand by this diagram the traumatic brain injury, the occurrence with regard to whether it is a primary injury, which is sudden, and the force applied on the brain causing damage. Secondary injury is the cascade of event which occurs after the primary injury. Location, is it a diffuse injury or a focal injury? That also play a role. Further, severity, is it a open penetrating injury with regarding to fracture of the skull, or else it's a closed non-communicating or non-penetrating injury? Based upon all these factors, the presentation of neuropsychiatric symptoms are known to play a role. Traumatic brain injury can also be influenced by whether it is a polytrauma, whether it requires emergency neurosurgical intervention, whether there was a neurological deficit, seizures, dementia, cognitive deficit, Alzheimer's dementia, focal neurological deficits, and cranial injuries. Psychiatric symptoms which can present either immediately or later. Invariably depression, anxiety disorder, post-traumatic stress disorder, OCD, psychosis, substance use disorder, cognitive dysfunction, and other behavioral sequelae are well known. Now let's look into the epidemiology of traumatic brain injury and neuropsychiatric disorders. Approximately 50 million to 60 million people have TBI over a period of 1 year. That means 5 to 6 crore people will have head injury every year. Of all common neurological disorders, traumatic brain injury has the highest incidence and prevalence and poses a substantial public health burden and emergency at this point of time. If you look at this diagram, it clearly shows out of all neurological conditions, traumatic brain injury, both incidence and prevalence are very high when it is compared to stroke, Alzheimer's disease, Parkinson's, and multiple sclerosis. My dear friends, traumatic brain injury prevalence is very high and it is almost epidemic now, my dear friends. More than 90% of the patients present to the hospital with traumatic brain injury, which are mild in nature. Only 10 to 15% are moderate to severe. If you take the milder version of traumatic brain injury, which is 90%, in them, 50% of them do not reach premorbid level of functioning. That means before the injury, whatever the functioning was there, they will not reach that. That means even after 6 months, they continue to have various other deficits and their quality of life and well-being will be impaired. Coming to the neuropsychiatric aspect of traumatic brain injury. It can be classified into immediate, acute, and long term. Immediate after the head injury, invariably, few of the patients will have disorientation, confusion, delirium, numbness, panic attacks, dissociative attacks, and many a time amnesia at that time. Acute, that means after the head injury, many of them will be taken to the hospital, and if they are already alcohol addicts or substance addicts, you can call them as a dependence, they will have withdrawal symptoms in the hospital because they do not have access to the drugs. Further, if somebody has a head injury and he may have epilepsy, post-epileptic neuropsychiatric sequelae can be triggered. I have made a separate video with regard to neuropsychiatric aspects of epilepsy. Please do visit my YouTube channel to know about more about of the neuropsychiatric aspects of epilepsy. Further, acute psychosis, panic disorder, and insomnia are common. In long term, concussion, depression, bipolar disorder, generalized anxiety disorder, OCD, PTSD, personality change, cognitive deficits, and dementia. These are the commonest psychiatric presentation post TBI, my dear friends. Further, traumatic brain injury and crime are closely related and they are bidirectional. Epidemiological studies from various developed countries such as Sweden, Canada, and Australia indicated approximately 2 to 3-fold increased risk of crime in individuals after TBI when compared to non-injured people. That means the people who are antisocial personals, who are involved in crime, there are high possibility they may have head injury. Further, if a person who have head injury may also get into conflict with law and he may be arrested. That means it is bidirectional, my dear friends. Now let's look into the pathophysiology of neuropsychiatric aspects of traumatic brain injury. As I mentioned earlier, the first and the foremost is primary injury, which is the force at which the brain was destroyed or injured. Secondary injury, which occurs because of concussion, hypoxia, diffuse axonal injury, focal injury of the brain, epilepsy related injury, hemorrhage, hypoxia, neuroinflammation, and also neurochemical disruptions with regard to dopamine, epinephrine, norepinephrine, serotonin, acetylcholine, and so forth. After the injury, there will be disruption along the axonal and also at the synaptic junction. This disruption can trigger various manifestation. So, my dear friends, the pathophysiological effect is either by primary or secondary, and in secondary, various mechanisms have been proposed. Further, what are the outcome related variables? The variables which clearly indicates the poorer outcome can be the older age, higher score with regard to severity, lower score in Glasgow Coma Scale, location of injury, polytrauma, alcohol intoxication, gender being a female, education, near death experience, comorbid conditions, and pre injury mental health, that is, pre morbid personality. Broadly speaking, prognosis in mild TBI is driven to an extent, greater extent, by the patient, what the patient brings to the injury. That means pre injury comorbidities and mental health play a crucial role in neuropsychiatric aspects. This you have to remember. In mild traumatic brain injury, what the patient brings to the injury. That means the person who has had an head injury, what kind of person he is. Based upon that, neuropsychiatric issues will be developing. Further, repeated brain injuries, genetic vulnerability, substance use premorbidly, that means before injury he was using drugs or alcohol, pre existing mental illness, poor coping skills, poor family support, social support, economical issues, insurance related issues, medical legal issues, focal deficit, and various disabilities play a crucial role in development of neuropsychiatric disorders. To summarize, in this diagram, it clearly talks about four important factors. One is brain variables, post injury personal variables, environmental variables, and premorbid person variables. Let's look into the brain variables. Here, the extent of damage, location of damage, type of damage, and development of complication. The second one is post injury personal variable, age at injury, emotional response to injury, physical and cognitive sequelae, degree of decline in functioning, reaction to change, ability to adapt and coping capacity. Environmental variables such as stressors, demands and expectations, quality of interpersonal relationship, financial or psychological gain. Finally, the premorbid person variables, personality, pre-existing psychiatric illness, pre-existing psychological stressors, cognitive styles, strategies, cognitive status, educational level, and occupational status. All these are the factors which play an important role in development of psychiatric disorder post traumatic brain injury. Let's discuss about the psychiatric aspects of traumatic brain injury. The most common is depression, which is 15 to 70%. The second one is dysthymia, 5 to 15%. Bipolar disorder, 2 to 15%. Generalized anxiety, 3 to 28%. Panic disorder, 4 to 17%. Post-concussional syndrome, 5 to 25%. Further, phobic disorder, up to 10%. OCD, 2 to 15%. PTSD, 3 to 27%. Substance abuse or dependence, 5 to 28%. And schizophrenia, 1%. As you look at this range, it clearly indicates that the way the tests have been done in post-traumatic brain injury patients. What was the timing of the study? What were the instruments used? What was the caseness used? Based upon all these things, this range varies between various at least 30 to 70% will have post-traumatic brain injury having psychiatric sequelae. Further, they may have non-specific symptoms such as agitation, emotional dysregulation with impulsivity, apathy, problem with arousal and motivation, slow cognitive processing, decreased attention and concentration, fatigue, headache, backache, multiple aches and pains, substance abuse, suicidal ideation, attempts, and death by suicide, my dear friends. So, the presence of psychiatric disorder post traumatic brain injury needs to be thoroughly evaluated and addressed. It can be easily classified like this. It can be classified into 5 important domains. Post traumatic brain injury, the psychiatric sequelae starts with cognitive dysfunction or neurobehavioral disorders, sensory disruption, somatic symptoms, or substance dependence or alcohol dependence can be considered. With regard to cognitive dysfunction, memory disturbance, disturbance in the attention and concentration, language and facial recognition problems, visuospatial cognition difficulties, executive function difficulties. Moving to neurobehavioral disorder, there will be mood disorders such as depression, bipolar, mania, dysthymia can be seen. Many a time, the patient may also develop post-traumatic stress disorder, anxiety disorders, GAD, OCD, PTSD can be common. Further, psychotic disorders are also well known. Moving to the third, sensory disruption, visual changes, dizziness and hearing loss, altered smell perceptions, altered taste, and hypersensitivity to touch can be seen. Moving to somatic pain, chronic headache, backache, multiple aches and pains, loss of libido, fatigue, and various other symptoms are well known. Finally, substance abuse or drug abuse is well known. These are the 5 important domains under which the manifestation of neuropsychiatric disorders are noted post traumatic brain injury. Now, let's discuss what happens to these psychiatric conditions over a period of time. That is, course of neuropsychiatric sequelae after head injury. This diagram clearly indicates over a period of 5 years how the psychiatric illness progresses, whether it improves or worsens. Any psychiatric illness, in the first year it is around 60%, by the end of 5 years, it will be around 40%, my dear friends. Any mood disorder or anxiety disorder is around 40%, and they continue to be there. Even at the end of 5 years, it will be around 35%. If you look at any mood disorder, which is also around 40% and continues to be there at the end of 5 years, up to 35%. With regard to any anxiety disorder, which is around 45%, but at the end of 5 years, it reduces to 20%. And moving to substance use disorder, my dear friends, which remains constant over a period of 5 years. So this is the neuropsychiatric course and outcome post-traumatic brain injury. Now let's discuss about the management of psychiatric disorders after traumatic brain injury. During the assessment, you need to keep important variables which are essential for treatment purposes. First of them, you need to know what is the reason for referral. Is it an acute or is it a chronic? Whether the referral is from casualty or else it is in the OPD. Now the next question is, what is the baseline severity noted during the head injury? What was the Glasgow Coma Scale? What was his post-traumatic amnesia? Whether there was loss of consciousness, loss of awareness of surrounding, those need to be clearly documented. Evolution of psychiatric symptoms. After the head injury, when did the psychiatric symptoms started arriving? What is the relationship between the head injury and the psychiatric symptoms to be noted? Past history of any psychiatric illness was there or not? Whether those psychiatric symptoms have worsened or not, that needs to be documented. Look into family history, social support, whether he has any medical comorbidity, whether he had polytrauma during the head injury, premorbid personality, what was his coping capacity, whether how did he manage his stress, and also do mental status examination, cognitive assessment, and also mini mental status examination. Invariably, Hindi mental status examination in India is very popular, that can be used easily. Scales can also be used to prognosticate the cases, especially in medico legal cases. You need not do prognostication in all cases. Further, if there is an emergency, referral is there in a casualty, it may be because of substance withdrawal, the patient would have developed epilepsy because of head injury or because of substance withdrawal, agitation, violence, restlessness, hallucinatory behavior, disinhibition, impulsivity, dangers to self and others, and so forth. Is this the presentation and what is the reason for referral will be clearly documented. Whether it is an acute and long-term psychiatric sequelae, whether it is the referral is for depression, suicidal ideas, suicidal attempts, bipolar disorder, GAD reason, PTSD, OCD, SUD, or else psychosis and so forth. What is the reason for the later referral? Finally, you may be also called for assessing the disability. Invariably, whenever you are assessing for disability, either for psychiatric disorder or cognitive dysfunction or even for the neurological dysfunction, you have to wait for 6 months at least, because within the 6 months, the improvement can be noted. However, after 6 months, the improvement will be minimal, or else you can do an assessment either at the 6 months after head injury, or else maybe after 1 year. Invariably, don't do any kind of prognosticating or disability assessment within 6 months after the head injury. Now, let's look into head injury and substance use disorder. Substance abuse increases the risk of head injury, and particularly the risk of multiple head injuries are common if a person is using alcohol or drugs. But at the same time, the studies also have clearly documented new onset of substance use disorders have been noted in 10 to 20% of the patients who had head injury and never had alcohol or drug abuse. That means the new onset of substance use disorders have been noted in drug abusers or substance use. That means it is bidirectional in nature. TBI can also interferes with the treatment of substance use, my dear friends. Let's look into this diagram. This is a diagram which was presented by Lucia and his colleagues in Nature Review Neurology. In this, they have clearly shown the relationship between traumatic brain injury and substance use. It is bidirectional in nature, and various factors such as social isolation, loss of income, loss of daily routine, family milieu, genetic risks plays a crucial role. Further, social attitude towards disability, poverty, racism, and factors, all these play a crucial role in outcome. Further, the person may start using substance for chronic pain, self-medication for anxiety disorder, mood disorder, depression, and he is worried about disability, cognitive dysfunction, psychological sequelae, or maybe even for PTSD, reduced efficacy of treatment, owing to poor memory, loss of frustration tolerance. All these may push him to use drug abuse, my dear friends. Further, TBI and criminality. As I mentioned earlier, various population studies have clearly indicated there is a high prevalence of head injury in incarcerated population, that is, in prison. In particularly, a history of repeated head injury is linked to the increased risk of incarceration across all offense types, my dear friends. Criminality and incarceration also is a risk factor for traumatic brain injury, which can lead to vicious cycle. That means head injury leads to criminality, and criminality can also increases the brain or head injury, my dear friends. Again, Lucia and his colleagues have shown the important bidirectional component of criminality and drug and head injury. Male gender, substance abuse, low socioeconomic status, family milieu, exposure to violence and trauma play a crucial role. Others factors like disrupted neurocognitive development, loss of criminalization, post head injury behavior, and also cognitive and psychological sequelae, all these play a crucial role along with poverty, social attitude towards disability, and various racism factors play an important role in criminality after the head injury. Now let's look into the post-concussion syndrome. Because it is called as a syndrome, because it is basically the constellation of symptoms that commonly occur in mild traumatic brain injury. Symptoms can be classified as physical, cognitive, behavioral, and emotional in nature. 70%, 75% of the traumatic brain injuries are very mild, and many a time they have said that 90% of them also can be mild. Approximately 15% of the mild traumatic brain injury patients will develop post-concussion syndrome. This is after 3 months after the head injury, my dear friends. That means you have to make a diagnosis of post-concussional syndrome after 3 months. What are the signs and symptoms? The commonest is headache, sleep problem, appetite change, fatigue, trouble in concentration, memory problem, depression and anxiety, sensitivity to light and noise, and dizziness. Invariably, most of the patient in the early part of the period of head injury will have these symptoms. By the end of 3 months, most of them will recover from this, but only 15% of them will continue to have post concussional syndrome. Let's look into the diagnostic criteria. As per the ICD 10, which clearly says at least three or more of the following symptoms have to be present, such as headache, dizziness, fatigue, irritability, insomnia, concentration, memory difficulty, intolerance to stress, emotions, or alcohol can be considered for the diagnosis of post concussional syndrome. In most people, symptoms appears within first 7 to 10 days, my dear friends, and they can persist for a long period. Invariably, within 3 months, around 70 to 80% of them will remit on their own. But however, approximately 90% of the concussion symptoms are transient and symptoms resolve within 10 to 14 days but may linger for weeks to months. The goal of treatment in post-concussional syndrome is symptomatic only. Please do take opinion from other specialty if the person has ENT injury, eye injury, neurological problems, psychiatric problems, or physiatrist. Opinion should be taken if the concussional syndrome clearly indicates some organic involvement also is there. In the treatment, education with regard to the symptoms and post-concussional syndrome to the patient and their family members, caretakers is very, very essential. This plays a very crucial role in the initial period of the symptoms because many a time family and the patients will be very apprehensive. What has happened to the brain has injured, what will happen to him, will he die? These are the apprehensions will be there. Sitting with the patient and the family member, discussing about post concussional syndrome, the outcome, what are the best things they can do are very essential. Reassuring that the symptoms are mild or they are self limiting, only few people will develop long standing symptoms, has to be told to them. And you have to assure them over a period of time, they will slowly diminish and it will not be any problematic over a period of time. Patients with litigation, compensation issues, insurance issues may have symptoms for longer duration, months to years, my dear friends. Mild TBI, once considered largely benign in nature, but now it is associated with larger other domains of symptoms such as affective symptoms, with suicidality, with worsening or new onset of symptoms such as severe psychiatric disorders, post traumatic stress disorder, and major depression. Hence, there is need to have a follow up of these head injury patients. If a patient has mild head injury, don't dismiss them. Please call them for follow up. You need to do follow up and look for whether there is an emergence of any psychiatric disorder at least for a period of next 6 months, if possible, up to 3 years maybe sometimes have been noted. Other symptoms such as apathy. Apathy is a puzzling phenomena mediated by the dissociation of knowing and doing, such that the affected individuals know what they need to do, but they do not be able to do anything and they are not be able to engage in any necessary task which they are supposed to do. That is, you can see apathy, complete amotivation, lack of enthusiasm to do anything. Apathy often accompanied by adynamia and abulia. That means they do not speak also. They have poor motivation to go to work or to do anything. They become completely rudimentary at home. Individual invariably exhibits diminished goal directed activity, behavior, cognitions, and emotional expression. Apathy is extremely detrimental to the traumatic brain injury recovery because they do not participate in rehabilitation activities, family relationship, social relationship, and occupational activities. Treatment for post TBI is very, very challenging. Invariably, psychosocial managements are the first line of treatment, such as behavioral activation, cognitive rehabilitation, and nowadays dopaminergic agents like rotigotin is being used, my dear friends. Now let's look into emotional dysregulation, that is affective liability. Here, it is characterized by intense and unpredictable emotional experiences and expression in response to internal or external stimuli that would normally provoke a moderate reaction or a mild reaction. Here, the patient will have severe emotional dysregulation. Sometimes the patient or the family members will talk about by naming as mood swings. Whenever the patient or the family member says he had mood swings, please ask them whether he has intense emotional response, expression, experiences need to be asked. It is highly injurious to interpersonal relationship and also difficult to treat, especially when it is coupled with symptoms of emotional dysregulation such as irritability and impulsivity. Affected individuals might describe their behavior as coming out of nowhere. They say, I become extremely irritable and assaultative without no reason, doctor. That is the way they put across. Rather than being a response to an individual or identifiable trigger or the culmination of minor irritation to a larger one, they say, this amazing emotional dysregulation occurs from nowhere. That's the way the patient and the family member explain. Although the Cochrane review has said propranolol may be considered for the treatment of emotional dysregulation, but however, later part of the studies have not supported it. At this point of time, we do not have systematic RCTs conducted for emotional dysregulation, my dear friends. However, various case studies, open label studies have said valproate, carbamazepine, lithium, and SSRIs can be considered. If you want to use lithium, my dear friends, please make sure the patient did not had head injury with seizures, my dear friends. So, if the patient has head injury and emotional dysregulation without any seizure, please consider lithium. Moving to mood disorders. Depression is the most common mood disorder in the post traumatic brain injury. Approximately 25 to 50% of the individual in the first year will have mood symptoms after head injury, with over 60% receiving diagnosis over the course of lifetime. My dear friend, that means the mood disorder does not only occur in the first year, and over a period of lifetime, they have these mood symptoms may be there. A recent meta-analysis suggested overall pharmacotherapy for depression is best and it has been very effective, has been noted. More recent studies have begun to examine whether SSRIs, specifically sertraline, could prevent later onset of depression when administered shortly after the head injury has been also been explored, my dear friends. But however, robust studies yet to be published, my dear friends. Moving to post-traumatic stress disorder. The PTSD presents with as re-experiencing, flashback, avoidance, numbness, arousal, anxiety symptoms, which are classical of PTSD, are well known. Traumatic brain injury usually an important risk factor for PTSD. However, given the evidence, the milder TBI, that is milder head injury, carries higher risk of PTSD than the severe TBI because the loss of consciousness after a severe head injury or moderate head injury, loss of awareness of the surroundings, amnesia appears to be protective for post traumatic stress disorder. Whenever there is a mild traumatic brain injury, who is exposed and remembers the event, that life threatening event, may be higher risk of developing PTSD. PTSD and traumatic brain injury is a higher risk for suicidal ideas, attempts, and death by suicide. Moving to anxiety disorders. Anxiety is often markedly marked shortly after the injury due to the stress of injury, due to the economical reasons, due to the pain, due to the suffering, and being in the hospital and getting adjusted to the new way of life prones for anxiety. Thereafter, anxiety becomes multifactorial in region. It can be biological, it can be psychological, and social insults can also cause anxiety disorder. There are evidences suggest an inverse relationship between injury severity and anxiety disorder. Milder the injury, they are associated with PTSD, social phobia, panic disorder, and agoraphobia. If it is a severe injury, they will have head injury with resulting concussion, loss of consciousness, loss of awareness, and memory loss. Hence, anxiety disorders will be minimal in those patients. Unfortunately, anxiety disorder in traumatic brain injury are under-recognized and under-treated, my dear friends. Hence, whenever a patient who comes for follow-up in traumatic brain injury, please explore for anxiety disorders, mood disorders. Moving to psychosis. The estimation of prevalence of psychosis in post-traumatic brain injury, it is hardly 1 to 10%, depending upon the study, depending upon the caseness of the study, and comparing with the general population, they appears to be 1 to 10%, my dear friends. The timing of onset of psychosis following TBI has a bimodal distribution of psychosis, which peaks of diagnosis occurs in the acute stage and again few years after the injury, my dear friends. Invariably, psychosis is commonly seen in genetically vulnerable population. The treatment is olanzapine, quetiapine, and risperidone. Invariably, haloperidol has been avoided because it interferes in rehabilitation, my dear friends. There is an important article which is published by Lucia and his colleagues in Nature Review Neurology. The title of the study is Psychiatric Sequelae of Traumatic Brain Injury Future Directions in Research. This is an important article, my dear friends. Whoever is the viewer, I request them to go through this article, which is a landmark article which talks about the psychiatric sequelae and what should be the future research purpose. In the same article, which talks about the management also. With regard to depression, it indicates psychotherapy and CBT, or else even medication has been considered. With regard to anxiety disorder, psychotherapy and sertraline and various other medication has been considered. With regard to apathy, behavioral rehabilitation, that is activation, drug treatments have been investigated with regard to the apathy, my dear friends. Moving to emotional dysregulation, that is affective liability, irritability, various medications and various psychosocial treatments have been considered. The medications such as valproate, carbamazepine, propranolol, antipsychotics, benzodiazepine, methylphenidate, sertraline has been considered. But however, the robust RCTs are not available. With regard to psychosis, atypical antipsychotics like olanzapine and also risperidone can be considered with quetiapine. Suicidal conditions, invariably, you need to consider what are the reasons. You may have to consider giving medications such as antidepressant or antipsychotics based upon the reason for suicidal attempt. Substance misuse may require inpatient admission. Multidisciplinary management is the only way with regard to substance use in post-head injury, my dear friends. To conclude, traumatic brain injury may lead to neuropsychiatric conditions in up to 60 to 70%, and 40 to 50% of them continue to have these symptoms after 5 years also. This is reason because disruption of brain network and neurotransmitters have been the hypothesis which has been proposed. There is a complex intersectional relationship exists between traumatic brain injury and neuropsychiatric disorders. They are influenced by both individual factors, social factors, and environmental factors. Common and important symptoms include mood disorders, anxiety disorders, substance misuse disorder, emotional liability, dysregulations, apathy, and suicide are the psychiatric conditions which are noted post-head injury, my dear friends. Neurobehavioral, neurocognitive impairments following traumatic brain injury are common and often persistent over a period of time. Both combination of psychopharmacology, earlier rehabilitation, and psychosocial intervention are the way to go in traumatic brain injury causing psychiatric symptoms, my dear friends. Thank you very much for giving your valuable time. Stay safe.